So for those of you guys who have never used the DSM before or have really only used it as something maybe in an undergraduate course, I'm going to give you guys an introduction into how to actually physically use the document. You may have a physical copy of this, it may be online, whatever you have, make sure you pull it up and it's next to you while we have this discussion. So you get your DSM out, turn to page 19, which is the use of the manual, and they kind of walk you through some of the sections. So I want to talk a little bit about this. So first, I want to make sure that people are aware that, so organizationally speaking, the DSM is broken down into chapters. Each chapter has some connective theme within the chapter, and so, or that holds all the things within the chapter together. Sorry. So, for example, your very first chapter are the neurodevelopmental disorders. So, every single disorder in there is held together by some common link, and that common link is always really important to know because when you read a case or see a client, you need to have an idea of what are the overarching large clinical issues so that you know what chapter to go to start looking for the specific disorder that you might have. So let me give you an easier example than neurodevelopmental. That might be kind of harder. Anxiety, right? Most people know what anxiety is. You probably know what anxiety already is. You probably felt anxiety in your life. And so if a person comes to you and their primary complaint is anxiety, it makes perfect sense that you're probably going to start in the anxiety disorder chapter. If somebody comes to you and they're having mood problems, their mood has been poor, you're going to go into one of the two chapters that look at primarily mood issues, the depressive disorders or the bipolar disorders. If someone is coming to you and experiencing psychosis, psychosis is the overarching experience that defines the schizophrenia and related disorders chapter. If a person comes to you and early in their lifespan there were some cognitive concerns that are neurological in nature, you're going to go to the neurocognitive disorders. So every single chapter is organized by one overarching psychiatric condition that is present in all of those disorders. Usually they are named in a way that makes it really easy to know what it is. Actually, I think they're named really well. I think the DSM's done a good job of making you orient toward them. So that is how the DSM on a large scale is structured. Now, it's also organized developmentally, meaning that it walks you through the lifespan of when disorders generally occur. So the very first chapter of the DSM is the neurodevelopmental disorders. Well, those are all based in early childhood, so they should probably be first, and they are. If you look at the very end of your DSM, you will see neurocognitive disorders and personality disorders. Those are things that you generally see later in the lifespan. So in order to diagnose personality problems, you have to be older because personality is still forming when you're a kid and adolescent. And then the neurocognitive disorders are all conditions that happen in the adult lifespan, things like dementia, Parkinson's, Alzheimer's, things like that. So it's organized developmentally. Also, within each chapter, the disorders are organized developmentally. So if you have a child coming to see you who is anxious and they are having a type of anxiety that's most commonly seen in childhood, so maybe separation anxiety, then you should look at the beginning of the anxiety disorder chapter, right? So developmental as a large structure, developmental within the chapters. That's the way the DSM is organized. So if you're seeing a kid, you're probably going to look in the front of chapters. If you're seeing an adult, it could be anywhere in the chapters. So that's one way to think about this. And I would use that to guide you every single case vignette, every single exam, every single client that you see. What are the big overarching problems? Are they anxious? Are they obsessive? Are they depressed? Are there eating problems? Is it trauma issues? Is it stress? So think about the big issues. That puts you into the chapter, and then the chapters individually are different. Now, within the chapters, you will have anywhere from a single disorder, so there's one chapter that basically has one disorder in it, up to many disorders in one chapter. And so, for example, the first chapter we're going to cover in this course, the neurocognitive disorders, is actually large. It has a lot in it, partly because a lot of conditions begin neurodevelopmentally for children, and they're all have slight variations in them. So what do you do with those variations? That's when you begin to look at the way the diagnostic criteria are written. So anytime you're making a diagnosis in the DSM, you have to meet the criteria listed for each disorder. I'm actually going to jump you over in the DSM just to show you what I'm talking about. We'll look at the very first one, which is, I apologize, we'll start with intellectual disability, which is on page 33. So it's going to introduce you to the disorder and immediately give you diagnostic criteria. You must meet all criteria unless otherwise specified in that chapter. Okay? So in this one, you have to meet all the diagnostic criteria unless the criteria tell you that you don't have to meet it. All right? So when you look at this, you have a little paragraph that says there must be a disability with onset during developmental period that has intellectual and adaptive functioning deficits in conceptual, social, and practical domains. So they're telling you in the beginning, early on, lots of domains, and the 3 criteria must be met. And they outline A, B, and C. So it says the following 3 must be met. So you have to have A, B, and C in order to check off criteria A. Once you have those, you would move on. Now in this diagnosis, that's all there is. There's just one set of criteria that you must meet all 3. It won't always be like that in all the chapters. Sometimes there'll be more. So for example, if you turn to page 42, I'll give you a second to get there. It's a language disorder. So criteria A, difficulties in the acquisition or use of language as indicated by the following 3. And again, you must have deficits in all 3. So there's A1, A2, and A3. You must have all of those. Then you go into B. You have to have B. So language abilities are substantially and quantitatively below ... Then there's a C. So you must have C. Onset of symptoms is the early developmental period. And then there's a D. You must have D. So in order to make this diagnosis, you have to have A, B, C, and D. Okay? So whenever you're making a diagnosis, part of what you're doing is you're just gathering symptoms, right? You're just gathering. So you're writing down every symptom that you see in an individual, and we'll talk about what to do with those in a few minutes, or maybe in a different video. So diagnostically, you have criteria for every single disorder. Now, sometimes the criteria are unclear. Sometimes they're confusing. Sometimes you want to know more about them. Right after the criteria in the DSM, so to keep us there on page 42 where we were just at, right after that there is a diagnostic features section. And that diagnostic feature section actually gives you a longer descriptive version of those criteria. So if you're saying like, oh, I don't really understand, looking at A3, I don't really understand what an impairment in discourse means. That doesn't make sense to me. If you read the diagnostic feature section, it will describe to you what that means. Now, also in every chapter after that, you have a lot of other sections. You'll see associated features and supporting diagnosis, development and course, risk and prognostic features. Every chapter has some of these. Some of them are only in certain chapters, so it just depends. So all of these have different importance. So an associated feature supporting diagnosis, that gives you an idea of what are some other things that you might see in the individual that could give you a heads up that you're in the right category. So for example, a positive family history of language disorders is often present. So anytime you're working with neurodevelopmental disorders, you always want to ask the question, does anybody else in their immediate family also have these kinds of concerns, right? If they've got a father and an older brother that has it, that is what we call an associative feature. So it just helps you to know, oh, okay, I'm probably in the right category here. Development and course, this section is going to tell you when you can expect the disorder to start, like when will you see the first signs of it or the first major symptoms, and then how does the disorder progress over time. We call that the course of an illness. So when does it develop, and how does it go once it develops? Those can be really important for things like mood disorders, like how long is it going to last for? When's it going to go away? Is it going to come back again? Is this lifelong? Those kind of things. Risk and prognostic factors. So this is going to tell you any factor that makes a person higher risk for getting this disorder, and it's going to tell you anything that makes a person do better with this disorder. That's what we call prognostic factors. So what's the prognosis for this? Is it good? Is it bad? Can things help? Can they not help? I think the section that you will use a lot in your career, but a lot in this class especially, is the differential diagnosis section. So the differential diagnosis section is always going to walk you through what are similar disorders to this one that it could be mistaken for, but in the written part of that, it tells you how they are different. So for example, on page 43, we're still in the language disorders. The first thing it tells you is how to know the difference between what is just a normal variation in language and what is an actual language disorder. All right, so it tells you how to make that differential notice. If you're worried that it's actually just a hearing problem, how to differentiate between a hearing problem and an actual language disorder. You might be worried, is this person just have an intellectual disability and their low IQ is because of is why their language problems exist? If you wonder that, you can read about here. How do you differentiate between an intellectual disability and a language disorder? So it's going to be a really important section, especially when you are stuck between two diagnoses. So if you're saying to yourself, gosh, I don't know, like this could just be intellectual disability, I'm not really sure. That little paragraph will almost always help you decide, do I have an intellectual disability or am I looking at a language disorder instead? Really, really helpful section. After that, you've got a comorbidity section. So comorbidity, if that's a new word to you, that is a term that means a condition that coexists with another condition, right? So if I have comorbid anxiety and depression, then that means I have two separate psychiatric conditions happening at the same time within me. They are comorbid together. Okay? So comorbidity is really important also in making diagnostic decisions because sometimes one symptom may mask itself as something else. For example, trauma will often mask itself as anxiety. And so someone's really anxious and you can't really get a sense if they are traumatized and that's why they're experiencing that or they have separate anxiety. But some anxiety conditions often occur comorbidly with trauma. So when you read the comorbidity section, what you're really reading for is what kinds of other conditions are most common with this condition. Because you can absolutely have more than one disorder. You could have two disorders, you could have three disorders. You may have seen cases in your own work experiences or personal lives where people have multiple diagnoses. For example, we know that autism has a really high rate of ADHD, a comorbid rate of ADHD, meaning that a lot of individuals with autism also get diagnosed with a separate attentional deficit hyperactivity disorder. So that's a fact that can be really important in terms of understanding the client, what you might expect to see from the client if you keep working with them, and then of course it has pretty big implications for what you're going to do in terms of treatment. So those sections are going to always follow every single disorder. That's why the DSM is over 1,000 pages, because they have a lot of writing to do. But they're all really helpful sections. So the section you need to be most focused on for now is the diagnostic criteria. What do you have to see to meet that disorder? You have to have evidence to check off all those boxes. So if it says one symptom is lack of sleep, you have to have documentation from the client that's a problem. So you have to have a client saying, yeah, I only sleep 3 hours a night. Or if one of them is, if you're trying to look at a panic attack, for example, they have 9 or 10 of criteria. We'll get there later. You have to have 6 or 7 of those. So you have to ask specific questions. Do you experience this? Do you experience this? And that allows you to get yes or no answers so you can check those boxes. Again, in diagnostic criteria, every letter, A, B, C, D, you have to meet those unless it explicitly says you don't have to meet one. And then within each letter, there may be even more to meet. So that's the section I want you guys really focusing on. There are also other elements of a diagnosis that I want to talk about quickly. If you look on page 21 in your DSM, they talk about subtypes and specifiers. So subtypes and specifiers are things that you see quite a bit in the DSM. The good news is when you are making a diagnosis, it actually tells you the various subtypes and the various specifiers that exist for that disorder. So the place you're going to see this the most at are in the mood disorders. So a subtype is a specialty type of a disorder that is within a large umbrella but underneath it. So you may have, for example, in the phobias chapter, right? There's one diagnosis for phobias. You have a phobia. But there are actually subtypes of phobias. Is it an animal phobia? Is it something with blood or needles or injections? Is it something about nature and the environment? You'll see that when we get that chapter. Those are called subtypes. And so when you can make a designation of subtype, you need to make that. And oftentimes, subtypes are even given a different code. Every disorder has a code attached to it that's actually next to it in the words. Specifiers actually give you more context to the current diagnosis. So specifiers just give you more sort of a meatier description of what's going on in one specific disorder. And so you may not have specifiers, but you may. So for example, if someone is depressed, there are a whole list of specifiers that if they are present, you are asked to specify that. Okay? So for example, with bipolar disorder, if people are moving in and out of their mania really quickly, we call that rapid cycling. That's specifying the kind of bipolar they have. Okay? It'll walk you through those, and I will walk you through those when we get to those chapters, but be mindful that specifiers also exist. A principal diagnosis, if you have more than one diagnosis, you are to list them in the order of the seriousness with which the person has experienced them, or the other option is which one is going to be the treatment focus. So if a client comes to you and they have bipolar disorder, they're also smoking weed too much, but right now their emotional instability is really a major problem for them, you would list bipolar disorder as their principal diagnosis. The second one's called the secondary, third is called the tertiary, but principal diagnosis is how you list that. So if you, in this class, you may see some cases that have more than one diagnosis. The principal is the primary diagnosis that seems to account for most of the problems and is going to be the primary focus of your clinical attention. A provisional diagnosis is a little bit different. So if you're sitting with a client and you've done an intake with them or some evaluation with them, and you feel really certain that they have a disorder, but you just haven't gotten enough information yet to make that known, but you feel strongly once you get that information that you will have the full diagnosis. There are two options for what you do with this. One I'll talk about now, one I'll talk about in a different video. So the first option is what's called a provisional diagnosis. So a provisional diagnosis is saying, I don't have all the criteria met yet, but I strongly feel like I will meet them all. If that's the case, if that's your situation, that's a provisional diagnosis. If the issue is, I haven't met all the criteria, and I don't think I ever will, but I really think they're depressed, that's something else. You do something else with that. So, provisional diagnosis is what you would give. It is a time-sensitive diagnosis, meaning that if you're telling me I don't have all the material yet, but I know I'm going to get it, my expectation, if I'm an insurance company, if I'm your supervisor, if I work in your clinic, my expectation is the next time you see that person, you're going to get that information. Lastly, there's a little bit of commentary about how to code it and how to write diagnoses. So next to each diagnosis are two codes. There's a number, and then in parentheses there's a code with usually an F and some numbers. The first is the DSM-5 number, so 300.1, 296.32 is next to it. That's a DSM-5 code. The number next to it with a letter in it, usually F, sometimes a V, is the ICD-10, International Classification of Disorders. We're the only country that uses a separate diagnostic manual for mental disorders. The rest of the world puts mental disorders in the overall system of all illness. So that's called the ICD. So if you go anywhere for medical practice in America, you'll get an ICD code, like strep throat or migraines. If you go to Europe, same thing. If you go to Europe or other countries for a mental illness diagnosis, you'll also get an ICD diagnosis only. In America, we have our own diagnostic system, the DSM. I can't say much about why that is, other than we're Americans. We like doing those things, I guess. So just be mindful that, and oftentimes when you do your billing requires ICD codes. So you will use the code next to the DSM code, and I'm going to ask you guys to report both codes in this class. That's your introduction to diagnosis. So in the next couple of videos, we're going to be moving into week 2, looking at neurodevelopmental disorders, and actually getting our hands in those chapters.